to pursue goals that impact the lives of our youth, communities, welfare of our members and families, we recognize the need to do more with efforts that encourages the health and well-being of our membership. Hence the latest effort and focus. So ladies, avoid any distraction and brace yourself to be enriched by a knowledge or two. I will now turn it over to Dr. Juliet Njoku and Dr. Cordelia Udo. I thank you all for joining.
Thank you so much, Lady Clem, and thank you all again, our members, for being here. We have within our midst able first presenter, and I'd like for us to just listen and hear just a brief bio about this amazing, highly accomplished doctor in our midst. Dr. Emeka Philip Igbodike is a consultant gynecologist, obstetrician, and minimal access surgeon. He's a fellow of West African College of Surgeons, fellow of National Postgraduate Medical College of Nigeria Faculty of Obstetrics and Gynecology. He's a graduate of NAMYAUSA University Teaching Hospital in 2008. Dr. Igbodike had his residency training at Obafemi Awolowo University Teaching Hospital Complex, Ile-Ife. He's a scholar and researcher with more than 35 scientific journals, published in both local and international journals in meta-analysis, systemic reviews, and random control trials, amongst others. His love for research earned him a merit award by the West Africa College of Surgeons as the best in dissertation writing, the Omi Wodun Prize. He has had several leadership training sessions. Dr. Igbodike also has a passion for charity. He is the chairman of Kiesel Richards Healthcare Foundation, a registered new charity organization that caters centers on free surgical care amongst underprivileged groups. He loves teaching and sharing information with junior colleagues and patients at large. As a result, he has been nominated as one of the speakers in the upcoming International Federation of Gynecology and Obstetrics Conference this October in Paris, France. He works with Kalina Advanced Minimal Access Surgical Hospital in Victoria Island, and a hospital consultant to Havana Specialist Hospital, Surulere. He loves classical music. Let's give a warm virtual welcome to our special guest presenter, Dr. Emeka Igbodike.
Thank you so much, Dr. Julie. Thank you very much for having me. Thank you, Mrs. Cordelia, and the host of other distinguished ladies and gentlemen. I suppose there's a man somewhere. Okay, thank you for that awesome introduction. All right, so let me know when I should start, because so that we can actually, am I free to go ahead?
The floor is yours. I just want to urge members one more time. Could you please, would you appreciate it if you could turn on your cameras and be on camera for this presentation? Would appreciate that greatly. Yes, Doctor, you have the floor. Thank you.
Okay, thank you, Julie. Thank you so much. All right, then, can I share my slides now? Okay, so you can make me a host so that I can share the slides.
Oh, yes. Awesome.
Okay, thank you so much. All right, then. Can we see the slides, please?
Yes.
Okay, great. Thank you so much once more, Julie, and the ladies present. I'm sincerely honored to be amongst you. I will be running through the series on ravaging cervical cancer and the need for a robust screening. I've already been introduced. Thank you. Okay, so let's go. You can see cervical awareness, HPV, and so on. We'll be hearing some of these nomenclatures as we go through the lecture. These are the outline. So I don't have any conflict of interest than that Dr. Udo has been talking about this, and today is a reality. All right, by way of introduction, in September 2015, the global community came together at the United Nations General Assembly to adopt an agenda for 2030, what is otherwise called the Sustainable Development Goals, the SDGs. And these SDGs actually said that cancers we are seeing as the non-communicable diseases. We'll be using the word NCD. That means if we have non-communicable, there are other communicable diseases. The World Health Organization estimates that 70% of cancer deaths occur in low and middle income class, of which Nigeria belongs to among other nations. That is the Sustainable Development Goals. You can see there are up to 17 goals, and we have quite a number of targets. So in 2030, it's estimated that about 24.1 million new cancers will be seen per year. And of course, the target again is low and middle income countries. That's a huge number, if you must agree with me. You look at the paradox, whereby in Africa, we talk about very high infertility, and also we also have quite a number of, when you talk about population. So it becomes a bit paradoxical where there is high infertility and there's also high population. How do we juxtapose this? As of 2018, the National Demographic Health Survey was of the opinion that the fertility index for that, what it means is that for a woman, an average woman in Nigeria, have at least 5.5 babies, so approximately 6 children. That's a lot when compared to other, clients like Sweden, where you have about 1 or 2. And robust screening exercises and political will and poverty is still holding Africa backwards. These are some of the challenges which we are going to look at. How do we tackle? By way of incidence, about 604,000, that's about 13 women per 100,000 women years, has been associated with cervical cancer. And in terms of deaths, there are about more than 300,000 deaths. That's about 7.2. And this is actually a figure from Globocan, all right? And the cervical cancer globally has been put to be the 4th. Remember that the 1st remains the breast cancer. When we look at in terms of women within their reproductive age group, about 60.9 million women, are at risk. Usually we talk about risk, classification. We are looking at the possibility that these women can actually have cervical cancer if nothing is actually done. And the human papillomavirus related cervical cancer is actually the 2nd leading cause of cancer death among women. That's quite huge. And every year, you can see a number of cases up to 7,000 die. And every day, about 28 women die from cervical cancer. That's a lot of burden, if you agree with me. Let's look at the risk factor for this cervical cancer. Now, usually you can see the beautiful slide there, looking at the early childbirth. Now, WHO has recommended that at least the average age for childbirth should be at least 18 years and beyond. But you agree with me that in some part of this country, you can see women delivering around 14. And there is a reason why the recommendation was made, because at that particular age, it's expected that the birth canal has been well developed and you don't have much trauma, especially to the cervix, which is the mouth or the womb, where you have the need of these cancers. Unprotected sexual intercourse is also on the high rise, and that has been, looked at as a risk factor of cervical cancer because of the lesions on the cervix during the coital, exposure. Then oral contraceptive pills. Somebody might ask, why should this be a risk for cervical cancer? Now, you see here, this is a woman that is having, that is on oral contraceptive pill. She believes she cannot get pregnant. Now, she now goes about having sex without necessarily remembering that there is also the risk of having cervical cancer. So the tendency of having multiple sexual partners, which is the upper part here, is also there because she believes that she's actually protected. Then having more number of children. Remember what we said again in terms of the fertility index of Africa, especially Nigeria, that an average woman have up to 5 children. And the more there is childbirth, especially vaginal birth, the more one increases the risk of cervical cancer. Then early marriage. This early marriage in jurisdiction of Nigeria has been a political stance, whereby the definition of the Constitution says that a woman should be allowed to get married when she has reached a full age. The word full age has been a very political statement. What do you really mean by full age? But the truth of the matter, remember what I said concerning the issue of early childbirth according to the WHO, that at least 18 years and beyond. So any child that is 14 and 15, of course, being married, of course, tendency of having childbirth is, of course, at risk of cervical cancer. Then family history, especially in 4th-degree relatives, the mother, then 2nd degree, the aunties and all those stuff. One should look out for the possibility risk in that particular individual. Smoking cigarette has been implicated to be a risk factor for cervical cancer. I weekly look at the highlights concerning the Sustainable Development Goals, especially the Goal 3, which is still referencing the issue of sustainable health for all. You can see that Goal 3A is looking at the issue of control of tobacco. Okay, tobacco is the smoking we talked about. The risk profiling of tobacco is still high, especially in Western world, and looking at how possibilities to cut down on this. And also the B segment looks at the issue of vaccines and medicine, how to make all these things affordable. So that, remember, we're going to talk about the issue of human papillomavirus vaccination. You see how important this B is, and for it to reach all. Then the C is looking at the issue of increasing health financing and recruitment. It will interest you to know that most of the budgets in Nigeria is as regards health, none of them is up to 10%. Most of them are less than 10% when you have to look at the whole total budgetary allocation. That shows you in terms of the interest. And when you compare this to other sectors of the world, you know why our HDI is actually low. We're looking at also some of the targets for this Goal 3. Remember, the issue of the whole is that, is there a way that at least 1/3 of prematurity mortality that follows non-communicable disease like cancer, how can it be prevented and, of course, treated? The reduction at least 1/3, that is actually the goal. And remember, the goal is by 2030. We're already in 2023, so just 7 years, away. Then target 3.8, you're looking at the universal health coverage. In terms of this is very important when it comes to NHS or NHIS, depending on where it is. All over the world, there has been the clamoring of the issue of insurance scheme, but it's worse off in low and middle income country, where almost majority of the women, they are not actually covered. And of course, when a woman has to do out-pocket payments, your guess is good as mine that that woman might not necessarily source for healthcare. Let's look at the burden of cervical cancer. Just 2018, about 8.7% of Nigerian women had pap smear, just 8.7, and that's pretty low. Then in 2019, human papillomavirus vaccine were only available in private hospitals. Imagine that. So that means that most of the government hospitals have one reason or the other why they couldn't, these are all facts from filed from reliable sources. About 3.5% of Nigerian women are estimated to be carrying cervical human papillomavirus 16 and 18. Mind you, these are actually the oncogenic strains, which are going to look at that they have up to 120 serotypes of human papillomaviruses, and that about 3.5 is carrying the oncogenic strain. And yet we have very low profile in terms of screening and vaccination. Let's look at the shortage of personnel and budgetary allocation of Nigeria. I said earlier that in fact, all the dispensation, there is none that have gotten health care up to more than 10% of total allocation. And that is pretty very bad. An average of 1 doctor per 1,000 people in Nigeria as we speak. And of course, when you look at the issue of oncologists, that is the cancer specialists, they are just about 90, which is to cover for all these people. And of course, about 5.7% of the total budget allocated to health as of 2023, just 5.7%. That is very low. And of course, we need to do more. When we look at the broader segment of the Human Development Index, of course, this is a metric complied by the UNDP, United Nations Development Program. It quantifies the country average achievement in 3 basic dimensions. And I want to lay emphasis on this dimension, which is actually the long and healthy life, then knowledge and decent standard of living. Of course, we are laying emphasis on the issue of health. So health determines the HDI of every country. And I'm sorry to tell you again that the HDI of Nigeria is very poor, is still within the 0.5 range when compared to that of United States, which is about 0.9. So we have a lot of things to do, a lot of work to do. These are some of the indicators we're talking about: HDI, the issue of poverty index, we're looking at GDP per capita, internet availability, and so on. And you can see the life expectancy. We are going to see a bit comparison for the two. So this is the classification of the HDI when it comes to different countries. And of course, you can see where USA is very high HDI. And of course, Nigeria is within the medium to low HDI. So we still have a lot of work to be done. Comparison between, this is Business Day Nigeria, of the HDI for Nigeria and USA. Like I said earlier, USA is 0.9, while Nigeria is 0.5. Life expectancy for Nigeria as of 2023, based on Statista, is 61.79 compared to 79 years in USA. And very poorly is that based on trending economics, that per capita income for Nigeria is $4,790, while for USA it is $80,034. So you can see the huge gap. Now, we are going straight now into the meat of the presentation, which is human papillomavirus infection. Up to 95, some textbooks equate 97.3% of cases of cervical cancer is caused by human papillomavirus infection. So if you look at this, you can see this man that this human papillomavirus is not just concentrating on the cervix. Now, for those, it can lead to vulvar cancer, oropharyngeal cancer, especially those who have oral sex. Okay, that's the cervical cancer here. Then the anal cancer, especially for those who have rectal sex, and of course the genital warts is for those that still HPV but for benign lesions, and of course penile cancer. So HPV affects both male and female, and it is something that is a bit worrisome. So these are the different types of HPV. I said earlier that in terms of serotype, there are up to 120 different serotypes. Sorry, please, 120. There are so many of them. But they are classified into benign lesions. Benign means non-cancerous lesions, while malignant means cancerous lesions. So they are numbered into 1, 2, 3, and up to, so you can see here, I'm going to concentrate on the common ones, 6 and 11. 6 and 11, they cause benign, so warts, okay? While that the malignant one is 16 and 18, which cause almost 50% of the cancerous strains will cause this. And these are some of the way it looks like a ball, looking at the histology. Now, can we have at least a little understanding how this human papillomavirus causes infection in man? It's very important. Now, let me say straight on that most immunocompetent individual, what do I mean by that? Those who they don't have any immune compromise, they don't have HIV, they are not on steroids, they don't have diabetes and all those stuff. These individuals have the capacity to do what? To clear up to 90% of HPV infection, can heal within 2 years of infection. All right, so this will actually inform when we now start talking about the period whereby we are going to start doing the screening, because the younger the individual, the more the tendency of clearing HPV in this bloodstream of that individual, which is good news. All right, so what happened is this. This is HPV infection. We're trying to have an inset of the cervix here. So these are all cells. All this that looks rectangular, and this line is the basal cell. Now, this is the histology. I'm going to make it as simple as possible. So this arrow is showing HPV coming to attack this cell. All right, every cell in the body has this structure. So it enters and stops here. Once it does not cross this line, this individual might have what we call precancerous lesion. That it is not yet cancer, but you can actually detect all those things by doing simple testing like pap smear, like HPV DNA testing, like VIA, and so on. Those testing will detect this. However, if this HPV infection passes this basal cell, we are no longer talking about precancerous lesion. We are not talking about cancer itself. So the beauty of HPV infection and the screening is to get the individual around this particular segment. So once you're able to pick them up, you can actually treat the individual and the individual gets well, and that's it. Now, when we look at the periodicity, when it takes for HPV infection to become cancer, some literature will put it between 10 to 30 years. So it's actually a long period of time before, you can see, look at that basal cell I talked to you about here is intact. It's no longer intact. It has entered, it has breached the basal cell, this line. So this is now an invasive cancer.
I'm not even seeing the whatever you are showing, Emeka.
Okay. Oh, yes. What did you say, ma'am?
I don't think
Yeah, good evening, sir.
Oh, you can see what I'm showing. Hello?
I'm not really seeing it. I'm not really seeing it, sir.
Wow, really?
Yeah, but all of us can see it. I think the rest of the people can see it. How are you logging on a phone or on a laptop?
On the phone. I'm logging
Yeah,
on the phone.
that's probably
okay.
why. Yeah.
That's the reason. Yeah.
All right.
Okay. All right. Sorry about that. Okay.
Thank
so
you, sir.
at the end of the day, about 0.8% can develop cancer. Look at where we started from and look at this. These are the people, the percentage that can heal. And at the end of the day, if nothing happens. So what happened is that the DNA, we must have heard of DNA, the DNA we normally talk about. These viruses, they have DNA too. So the DNA of this virus will integrate with the DNA of human, and they will now start copying, behaving as if they are now part of us. Of course, they are not, but that is what they do. All right. Can I go on, please?
Yes, you can go on, sir.
Okay, thank you.
It's not here.
Are we good?
Stop for that.
It's not very rude. Unless you
can anybody hear me?
Easy, can you please mute yourself? Everyone else is good. Go ahead, doctor.
Okay, all right then. So we are looking at the HPV according to
you have to talk, you have to unmute and talk so that they will hear you.
There is an interference.
Easy, can you mute yourself, please?
I'm sorry, ma. I'm sorry.
Dr. Juliet, can you mute everybody?
Dr. Igbodike has the hosting ability now, so I'm not able to mute everybody.
Okay.
That's okay. Go ahead.
Okay. Let me. All right. Sorry. Okay, great. So now we're looking at the HPV. Remember when I say HPV, I mean human papillomavirus. So I'll be showing HPV subsequently. Okay, great. So the McAnderson group was able to show this beautiful, and we said, okay, in terms of about 11 or 12 ages of boy or girl should receive HPV vaccine. All right. And of course, I needed to, this is my reference, what I want to reference, that about 75 to 80%, the average person lifetime risk of contracting HPV. This is very high. So that means if we have 10 people in this room, at least about 8 of them will get HPV infection. That is huge, all right? But the good news, remember what I said earlier, is that most of us, once you're immunocompetent, can actually clear this from the system. All right. Okay, so what are the signs and symptoms of human papillomavirus disease or infection, and of course, vis-a-vis cervical cancer? Now, for benign lesion, remember we said benign is not cancerous lesions. They can actually appear like what? What look like as if they are palm frond lesions that are on the skin, that are just there as if they are like feather. It might not be painful depending on the stage, and this can be quite worrisome. Then for the cancerous lesions, the woman can have postcoital bleeding. Even at the level of human papillomavirus, the woman can have, so what do we mean by postcoital bleeding? Bleeding after sex. A woman after having sex actually start bleeding. That's quite worrisome, and the woman will wonder what's going on. So if this happens, but let me say this as a disclaimer, it is not all the time that there is bleeding after sex that there is actually cancer. Sometimes cervicitis, cervical infection can actually lead to that, or even a woman being dry during sex, that can lead to that. So, but it's important to find out from your health personnel what's actually going on. All right. Now, for the cervical cancer symptoms, waist pain, you have this chronic waist pain. Let me say again, there are other things that can also cause waist pain. All right, like endometriosis can also cause waist pain. And so it doesn't necessarily mean that when there is waist pain, it should be cervical cancer. Their postcoital bleeding is coming up again. Then intramenstrual bleeding. What do I mean by this? Bleeding in between menses. All right, menstrual cycle is defined as the beginning of one menstrual cycle through the beginning of another menstrual cycle. That's the menstrual cycle. That's it. So inter means a woman, let's say, for instance, has 28-day cycle, start bleeding again by day 14 or 13, as if she's having a new, menses. That can be worrisome. However, uterine fibroid can also give you something close to that, and sometimes endometriosis too. Then foul vaginal discharge. Foul vaginal, very foul smelling vaginal discharge, that can also suggest. Again, not all foul vaginal means that the woman has cervical cancer, all right? Then progressive weight loss, the woman can become nauseous, and all those issues also. Now, most of the time, the signs and symptoms can come as a litany of most of these things all happening in one woman. And that becomes, of course, where there is distant metastasis, then we are now looking at the issue of affecting urinary bladder, the rectum. The woman might start bleeding during urination or bleeding through the rectum. That she definitely have to check that out. All right, so let's look at this graph. Now, the population prevalence, of course, not a scale. We are looking at, if you look at this graph, you can see that from age 9 to up to 14, there is a peak of HPV infection But around this peak, as it's coming down, it is clearing, and of course, it plateaus from here. All right. So now, most of the bodies, they use some of these technicalities for their screening. Now, most individuals in a same climate and setting, a girl that is 9 years up to 14 is not expected to have had sex. I'm talking about, say, I'm putting something constant. So if that is the case, then most vaccinations should occur around this point, between 9 to age 14, because it is better for HPV vaccination to be given around that age bracket. The reason is this: once a woman is infected by HPV infection, it becomes difficult. It becomes difficult for those HPV because they must have integrated into the DNA. Remember when we talk about pathophysiology? So the vaccination might not affect those ones that are already integrated. So he's targeting those ones that are still loose and he can clear them. So that's why it's better given at this point. However, any woman can actually have this up to age 26. If you look at this graph again, you can see that this is around 26 years old, but there's a caveat. If you have not had it at all you need to do is to do HPV. If you are negative, you can have it no matter your age. So that is how CDC, a Center for Disease Prevention and Control, puts it, okay? All right. Now you can see where pre-cancer is coming up around, say, 25 years. That's why World Health Organization will start their screen around this age. Some of the clients will start around 21 years, but we're going to see that. You can see that all of them plateaus around 60. By age 65, nobody disturbs any woman about screening anymore. All right, so let's look at in terms of primary, secondary, and tertiary prevention. We talked about, I mentioned this before, HPV vaccination. So you can see from age 30, this is WHO, and 25 years for women living with HIV. Then, of course, all women are needed. That's tertiary now. Okay. The girls and boys should also be offered. Yeah, in some climes where money is not the problem, they vaccinate not just girls, but they can also vaccinate boys. Yes, because boys can also harbor HPV infection. Then look at this, the issue of tobacco. We talked about it. There's sexual education tailored to age and culture. Protective sex. In fact, there is a concept of what we call the safer sex. Safer sex is that an individual is using condom not just to prevent getting pregnant, but also to prevent having sexually transmitted infection. So that is what is being advocated. Male circumcision is very important because when the foreskin is removed, which sees some of those HPV infection, they can not have anywhere to hide anymore. So in that point, male circumcision is actually a recommended health care intervention. All right. Okay, so let's go. Yes, it's still the same issue. Now, these are the number of doses. You might not bother yourself with it. When you get to the hospital, they will actually help you with that. But usually 9 to 14, 2 doses might be okay. Between 15 to 26, about 3 doses. And of course, it's spread out between 1 and 2 months, or 0, then 6 months, 0, 1, and 6 months. So these are just the, the vaccination. Now, we need to look at the issue of vaccine refusal. Some parents are a bit hesitant in terms of vaccinating their children. So what could be the reason? So look at this survey. This survey looked at this about from Johns Hopkins Medicine. So in 2020, 2010, 2016, and this is girls and boys. We're looking at what the issue cited by parents. About 22% says safety issue. They are not comfortable. They don't know whether it's safe or not. Some believe that this is not necessary. Some don't even understand why it should be given at all, about 13% of cases. Some said absence of physician recommendation. No doctor told them that they should vaccinate their kids. And of course, they assume that their children are not sexually active. So you can see the reason, and of course, gender necessity, because it's a girl or because it's a boy. About 30% said it's not necessary in boys and all those. So these are some of the issues where people raised concerning the issue of HPV vaccination. Now, this is again something similar. Reports indicate the uptake of HIV is not nearly as high as that. Okay, now, parents do not perceive their children to be at risk for acquiring it. So this is also another study, but from Medscape, about why there is vaccine refusal. Some are uncertain, about 4% of cases. About 71, the majority believe that parents do not perceive their child to be at risk for acquiring a sexually transmitted infection. Imagine. So they thought it's just an immediate something, but they don't know that it's actually something that's supposed to protect the child lifelong. All right, let's look at the recommendation, according to American Cancer Society, among others, when the screening should commence. Usually under 21 years. Hello? Hello?
Go ahead, you're good.
Somebody...
Hello, we're hearing you. Go ahead.
Okay, great. Okay, so under age 21, of course, there is no recommendation. Remember what I said earlier when I was showing us that graph, that majority of immunocompetent, that is those that don't have any form of immune reduction, HIV, they are not on steroids, they will clear this infection from their, from their system. But however, this American Society recommends that from, 21 years up to 29, of course, they should do pap smear testing, which is recommended every 3 years. Now, from age 30 to 65, there is a I put this in red. This is so important because in some hospitals, the women will just do pap smear and say that's okay. No, it's not. If a woman is between the ages of 30 to 65 years, pap smear may not be enough. You may have to do what we call a co-testing, or what we call HPV reflex testing. This HPV reflex testing increases the sensitivity of knowing if you have those high-risk HPV serotypes, like I mentioned, 16, 18, among others, okay? Now, if an individual happen to do pap smear and do HPV, and HPV is negative, the next time she will be screened will be in the next 5 years, not 3. But if she happens to do just pap smear alone, she will be screened the next 3 years. I hope that's very clear. Now, from age 65, it suffices us to know that after age 65, that with adequate negative pap smear, that you should actually stop screening that individual. All right? Yes, you can. Provided, remember that the caveat is that there has been evidence of subsequent screening have been negatives of intraepithelial lesions. So the woman is now 65 years old, leave her alone. But if the individual had some abnormal pap smear testing, or in colposcopy, which we are going to see, there are some lesions you may have to continue within the last 20 years. Should not be screened for cervical cancer with any modality. So, so these are all some of the things we have to look out for. This is just a summary of all we have said, but I just put this because of the exception. Remember I said no pap smear if previous pap smear were adequate and negative. Now, exceptions is abnormal results. You continue screening. The women that have HPV vaccine and the post-hysterectomy and use individualized schedule. So sometimes women must remove their womb for one reason or the other. If the reason, listen very carefully now, I'm going to make this thing clear. If the reason of removal of the womb, that is hysterectomy, is for non-cancerous reason, you might not continue screening if she has had subsequent normal results. But if it were removed because of maybe suspected cancer of the, say, the uterus or something, please, that individual should continue using. However, we use the word individualization of cases because it depends on the physician to know whether to screen or not to screen. based on what is before him or her. This is a very important, very, very central part of the discussion, the pap smear testing. Now, even among health workers, if you ask a lady friend, Madam, have you gone for a pap smear? She said no. So we are wondering why. Some are afraid, some believe it's painful and all those stuff. This picture shows what is pap smear is all about, all right? They're usually a brush, cyto brush. You know, the woman is lying on the couch that will go inside in the cervix, turn around, this is the arrow, 180 degrees, take it out, put it inside the LBC, liquid-based cytology, you know, liquid, that's all, that's all. These are about few, I mean, it doesn't take time. You know, there are some things you shouldn't doubt about, you shouldn't have sex within at least the past 24 to 48 hours before you do the pap testing, so that we just know that this is essentially what we are looking at. The same thing happens with colposcopy. All right, so that's it. That's the lady now, you know, speculum. People, most individuals, I'm yet to see a single woman that likes speculum. All right, but we have to see the cervix, okay? And that is the brush here, usually a very soft brush. Then, of course, now we don't do this Petri dish anymore. We put it rather in LBC, because this LBC allows us to do what we call reflex HPV testing. So you can use the same sample to do both pap smear and to also do HPV DNA. Beautiful stuff. So you don't need, so once you just have one stage stuff, you pick that, put it in the liquid. From there, you do your pap smear. From there, you do your HPV testing. Yes. Now, this is the WHO record. I told her that WHO is a little bit conservative with respect to the time of, you know, you start the screening. The one I showed, the American Cancer Society said from 821, you know, above. But WHO is saying 30 years. So it depends on what your center is doing. Your center should have a local control of why they are doing what they are doing, all right? And of course, I've said this earlier, that is 5 to 10 years, so that we don't repeat ourselves because of time. So this is the typical LBC medium, and this is the side, the brush. This brush is very soft. I might ask my patient to please, Madam, can you touch the brush? You know, it comes in a sealed pack. She will touch it and see that it's soft, so that she will not be scared. All right, yeah. So, okay, so this is the pap smear result. I'm not going to bother us with this, but just know that your pap smear can either be normal or abnormal. So abnormal is from here downwards, okay? From here downwards. There are some technicalities which may be a little bit postgraduate. You might not have to go into nitty-gritty, but just know that once they said your result is, they write it this way, negative for intraepithelial lesion. Negative for intraepithelial, that's a good result. But once you start seeing ASCOS, LSIL, you know, they know that it's an abnormal, and of course, your doctor will ask you to repeat it in 6 weeks, in 6 months, or to go in for colposcopy. Now, let's look at the concept of colposcopy. The colposcope is a machine that you will hear in the clinic, but it can only come up if there is a reason, or there is a result that is actually abnormal pap smear result. Colposcope, that's the machine here, it actually magnifies the cervix, the mouth of the womb, it makes it bigger, and we put in some, you know, some acetic acid, there are some changes from whitening, then we take targeted biopsy to now look at it, whether the individual, how we call CIN1, you know, 2 or 3. You know, these are all some of the lesions we have, and the treatment modality will differ based on whether it's CIN1, CIN2, or CIN3. But what I want us to understand in this lecture is that if your pap smear or the pap smear is abnormal, your doctor might suggest either of two things. The first is that to repeat the pap smear in 6 months, or to go straight for what's it called, for colposcopy, all right? So, and of course, the essence of colposcopy is to magnify, put some acetic acid, there will be some discoloration. You take targeted biopsy, and of course, we now show whether there is CIN1, CIN2, or CIN3, and of course, we recommend further treatment. All right. So that's colposcopy once more. So this is the way it looks. So for an invasive cancer, it appears this way. So, you know, irregular surfaces, bleeding ends, and all those, see some changes. This one is yellowish and all those stuff, you know. So atypical vessel patterns can be seen. These are all vessels. And of course, they might take biopsy in some of these ones. And then, of course, before one can definitely, so that's the acetyl white area I was talking about. That's it down there. Okay, so management is usually tailored into whether it is a precancerous, I've said it earlier on, or whether then for precancerous, it's either a CIN. You know, the 1, 2, 3 can either be burnt away, what we call ablative, or can be cut away, what we call excisional. These are all different modalities. Then for cancers, the individual will now go for radiotherapy, the local ones, and extended beam. Okay? All right. Now, is there anything that is new so far? It suffices us to know that World Health Organization now encourages countries to use HPV tests for screening. We said it earlier. And these are now HPV DNA. Remember I said that it increases the sensitivity. And now there is a second one, HPV mRNA test. Now, the beauty of these two is that HPV DNA testing detects high-risk strains of the HPV, the high-risk strain. Remember what I said? So once you are able to do HPV DNA and you are seeing 16, 18, 33, 35, 58, 42, and so on, that individual must go for what? Colposcopy. You're not going to wait, because what it simply means is that there is a tendency of this individual having cancer of the cervix over time if there is no intervention. That is the beauty of HPV DNA. Okay. Now, better still is another new, oh my, this is great. Okay, great. Better is the HPV mRNA, messenger RNA. That's the full meaning of this. It detects HPV infection leading to cellular transformation. Very important. So those ones that can, this one, the first one detects the high-risk strains. The second one will detect the HPV version that will lead to cellular changes. Those things that we are calling CIN1, CIN2, they are all cellular change, what we call in pathology dysplasia of the cervical length. So 1/3, 2/3, and the whole cervical length is called CIN1, CIN2, CIN3. All right. So those are the names, but mRNA can actually detect it, which is very, very good. Now, for the women that they don't want to come to hospital, there is a concept of self-collected samples. You can actually collect your own sample yourself in your bedroom, package it, and send it to the hospital. Imagine that. So, however, for the HPV mRNA testing, that cannot be done because of some reason. This is a pack of, the HPV DNA. You can actually do it in your bedroom. Your doctor and the nurse can tell you further what and what you should do, how to squat and all those stuff, and collect it. All right. Yeah. So the question now is, concerning the two, if you know pap smear versus HPV self-sampling, what would you rather choose? Remember I told you that I'm yet to see any woman that likes speculum. They don't like it at all. So this HPV self-sampling, would you rather go for that one? Okay. Let us conclude this webinar. We may have to adopt the use of panty condoms. I left this at this point because it is important to stress this. Now, the regular condoms, male condoms in the market, in fact, cannot prevent against human papillomavirus infection. That is a wow. Yes, you heard me right. Now, the contact between the labia and the scrotum, what we call labioscrotal contact, is enough to transmit HPV infection. So if HPV is in the scrotal skin of the man and it touches the labia of the vagina of the woman, that's enough. You remember that the condom just covers the shaft of the penis, so the phallus. So that means it can still, however, but there's a concept of what is called panty condom. It's one like a pant. It covers the phallus and also one around, so that the so there is no contact whatsoever. That labioscrotal is discouraged. So, but how common and how comfortable will people do this? Vaccination is a way to go. We have gone through the list of why people don't like vaccinating their daughters and their sons. We should educate others. We can try to discourage early sexual debut. The people, because of the media, so people have sex early, but there are consequences based on what we have learned today. Let us discourage early marriage. I mean, people should have time, 18 years and beyond, before they start talking about this. And the issue of ABC, of, abstinence, for those who can, of course, that is the 100%. There is no contact whatsoever. Be faithful to one partner. Remember that the issue, we talked about the issue of multiple sexual partners, having more than one partner within the period of 6 months. That is quite, significant. And of course, the use of panty condom, then recommendation of male circumcision is also very important. Then screening. Pap smear, HPV DNA testing, HPV mRNA is recommended highly for every woman that is eligible. Early diagnosis is very important and central. And of course, early treatment is advocated. Thank you very much, ladies and gentlemen. I think we should stop here so that we can take in questions.
Thank you, thank you, thank you. Ladies, can we please put our hands together for Dr. Igbodike? Oh my, oh my.
Powerful.
I bet we did not know what we were in for. When
Yes.
Oh my goodness. This is so much more than we expected.
Yes.
And I know that a whole lot of us have a whole lot of questions. And I know that Dr. Igbodike also said he'll be gracious enough to take as many questions as we have. I'd like to start by asking Dr. Igbodike, because when you were making your presentation, you did mention that we're only 7 years away from the UN Sustainable Development Goals. And it doesn't seem like we're anywhere close to even achieving the benchmark for Nigeria regarding, the testing, screening for PVI. And it also appears that the major issue is economics, right? So are there any things that are being done? What is being done to really mitigate this? Because again, we're only seven years away from the—
Years away. Okay. Thank you very much for that very intelligent question. Yes, as we are worried, we are also worried. There is something that is very central when it comes to healthcare advocacy, and of course, getting the healthcare to touch the grassroots. What is central is budgetary allocation. We said that in all the administration, none has gone beyond 10%. Even in 2023, we are still about 5.75%, about 1.7 trillion. What are you going to achieve with that? What are you going to achieve with that? We're talking about the issue of screening exercise. In some Western countries, there are people get text messages to come for their HPV DNA testing or to come for their pap smear. They receive text message. We've not even achieved that. We have different districts where people are, okay, women are still paying out of pocket in 2023. So there are a lot of, we have a very poor political will.
Wow.
Political will. Politics is so important because that we talk about policies. When people have good policies, they know that the HDI of every country is one of the key strengths is the health. So it is unfortunate, but we are also we are confident that if we continue to press on politically the way we are going, that one day we get it right. And of course, once we fix it right, it affects other sectors. Thank you.
Thank you so much. Ladies, if you do have questions for Dr. Igbodike, can you please use the reaction to put your hand up, and I'll call you to ask your question.
Can I ask a quick one?
Say that again?
Can I ask a quick one?
Sure, sure.
Thank you very much for this exciting and knowledge that really baffles some of us. One of them is that the vaccine is not available in public hospital. It's only in private hospital. What is the resistance to the government? I mean, why is that so? And why is it that they keep not providing the funding that is needed? And yet they want actually to restrain healthcare workers from leaving the country. But you cannot assure them that while you're there, we can make your work easier for you and the public.
Well, it is still work in progress. I mean, each and every one of us know that in Nigeria, we are in a particular struggle to see if we can upscale in terms of our political survival to at least match a little bit. We didn't say to be equate, to match a little bit to what we see in the Western world. Yes, we know that corruption and all those things is widespread, but in some centers, it is just as if it's now a way of life. And that is what we see in Africa, and especially in Nigeria. And we are still advocating that, what do we do? So right now, individuals are speaking out. People are coming out, people are creating awareness of, especially in our women, that you need to do this. But agencies, NGOs are also trying to see where they're going to come in, to see how they're going to cut the ice. Because if you keep on waiting for the woman in the market to go to the hospital to get tested, you might wait forever. So NGOs are doing pretty fantastic. People are giving back to the society. You know, when you move away from the shore of the country and you believe that God has blessed you, there's always a way to give back. You know, sensitize women. Remember that when you are able to screen just one woman, you have done a lot for that generation, just one. You know, and imagine where individuals are taking it upon themselves. They are doing this sensitization, they are doing this screening, they are even empowering women. Remember, the issue of the weaponizing of poverty is also one of the key, prongs that was talked about the issue of sustainable. That's the go to the issue of poverty issue. The hunger is one, then poverty too. So if we can reduce poverty and empower these women, they will look for the hospitals. I mean, they can afford these things, they are informed, and of course they will get tested. So we all have to be patient and continue raising this awareness and in the cause to see that one day, we don't know when, but we know that it will come very soon, that we'll all smile and say, this is my homeland and I'm proud of it.
Thank you so very much for that response, Dr. Igbodike. I think we have one hand up. Lady Ngozi Azu, could you please go ahead and ask your question? You're still muted. Okay.
Okay. Thank you very much, Dr. Emeka Igbodike. I was very, very proud listening to your teaching. I'm a nurse practitioner, so family medical nurse practitioner. So I read about cervical cancer and what I've learned, some of the things I've learned, I've never learned it before. So hearing your teaching all the way from Nigeria, this really amazes me, and I'm very proud of you. So I just have a quick question regarding the 2 weeks rule for cervical cancer. How does that play in Nigeria?
Okay, come again.
The 2 weeks rule for cervical cancer, like when a woman is detected of having when they're positive for the HPV virus and all that.
Yeah.
How does it
Okay. Well, unfortunately, that is not yet applicable. All right, it is not yet applicable. But what I do know is that for those women that happen to come in to be tested, usually there are ways we target them to bring them in. First of all, is that post-delivery, we ask them that after 3 months, they should come in. Then, of course, the 2 weeks is usually the period for the turnaround time from the pathologist to give us results. Most of the time we get these results, sometimes in few occasions, but because what we do is that we ensure a good communication gap, because most of the time when they pull samples before they run them, okay, so if we get a lot of women within that particular cohort, that 2 weeks happen. But I will tell you that most results, in fact, I have sent a woman to do a pap smear result, and in 2 days' time, the result was out. However, the laboratory that she used was a private laboratory, so it was quite quick. But what we use, especially in teaching hospitals, is 2 weeks. Once after pap smear, the patient comes back in 2 weeks, then you review the results, discuss with her whether it's normal, whether it's abnormal for further testing. So it works out well. But where we have the bottleneck is the awareness and ability to come at all to be screened. So, but once we get them screened, most of the time we get the result. And of course, I will tell you that most pathologists are doing pretty well,
Thank you so very much.
Thank you so very much.
Thank you. Thank you, Lady Ngozi, for that question. And thank you, Doctor, for the response.
Yeah.
Lady Ngozi, you can lower your hand now. We also have Chizzy, who has a question to ask. Chizzy, go ahead.
Okay. Thanks, Dr. Igbodike. I'd like to appreciate you for this topic. My question is a pharmacist that practices here.
Yeah, cracking, ma'am.
Chizzy, your connection is not coming through clearly. So we're only getting bits of what you're saying. Okay, could you go ahead and type your question, and I'll read it for the doctor, because we can barely hear you.
Chizzy, you want to place your phone very well? Introduce yourself too.
Yeah, we can barely hear her. If you can type, just type your question on the chart, and we'll read it to the doctor if that helps. We have another hand up, and that's from Dr. Esochi Homa. Could you go ahead and ask your question?
Hello, and thank you, ladies, and more special thanks to Dr. Igbodike. By way of introduction, Esochi Ihama, a dentist by profession, practicing in the Northeast region of America. And the question I have for Dr. Igbodike, by the way, thank you so much, though, is we know that these cancers the benign lesions have a tendency also to turn malignant. And my simple question will be, do we have an idea of what the incidence is of these benign lesions turning cancerous? And would that in any way help to or affect the the necessity really for the emergency for even extra or more scrupulous screening for these cancers?
Okay, thank you so much. Well, there is a very clear-cut, discussion when it comes to the issue of serotypes and which of them causes benign and which of them will now cause malignant lesions. So most of the serotypes, that can cause the benign lesions will remain benign. However, that does not necessarily mean there cannot be coexistence of the benign and the malignant lesion. Now, that is why it is very important and central that for women, somebody is interfering. That's why it's important that for women from age 30 to 65, the American Cancer Society is advocating that it may not be necessary just enough to do only pap smear. Because pap smear, we only tell you whether, there are intraepithelial lesion or negative and all those stuff, but it will not tell you as regard the serotype that are present. So if the individual has serotypes that are oncogenic strains, like serotype 16, 18, 33, 35, 52, and so on, that is a risk that is quite, risky, because if an individual has serotype 16 and 18, which they actually make up to 50% of in terms of cancer that can cause the malignant tendency, that individual is seriously at risk compared to 6 and 11 that causes the benign lesion. So the caveat here is for that particular individual, don't be comfortable with just pap testing when you are 30 years and beyond. So I like in my clinic, I make it a point of duty once you are 30 and beyond, after I finish writing for pap smear, immediately below I will write for HPV DNA testing. All right. I remember in one of the hospitals that I was a visiting consultant, I went there and I wrote this, they were confused. I say, yes. I say, pap smear is not enough. I have to educate them about what I've added. So what I'm trying to say in essence is that HPV 16 and 18 will cause cancerous lesion in up to 50%. So if there are two individuals and one of them, both of them have 16 and 18, at least one will have a cancer because that individual has HPV 16 and 18, which is quite huge. All right. However, if during the typing and what we are able to see are mainly the benign lesion, which is 6 and 11, 1, 2, 3, and so on, you might not necessarily bother. So because these things are, the DNA testing are so sensitive that they can actually type that woman and tell you that, madam, based on your HPV typing, we are not very comfortable because you have the oncogenic strains. All right. However, if the strains are benign, you might be relaxed and just put the woman on the normal regular screening, but you have to also screen the woman closer because there is already, she is HPV positive. That, mind you, it's just that the typing is benign. But here is another woman, HPV negative. That means there is no HPV seen at all. But this one is seen, but it is benign. That means you keep an eye on that woman because you don't know when you do a repeat screening, which may be, of course, once you see that you can do a colposcopy or whatever, especially in high risk, this thing, for you to now know that I need to do more. So I don't know whether I'm able to tease out your question.
Yes, absolutely. But as a follow-up to that, the cancerous serotypes, do they have equal oncogenic ability?
No, they don't. No, they don't. They don't. Now, for the oncogenic ability, WASOF is 16 and 18.
Okay.
Then the second category is 31, 33, 35, 52, 58. These ones have that the second category. But in terms of the virulence, it is WASOF in 16 and 18. 16 and 18 is so bad. Once you see it in a woman, you are so uncomfortable. But if you see the other one, they can, but not as virulent when compared to 16 and 18.
Thank you very much. Thank you. I appreciate you.
Yeah,
Thank you, Doc.
welcome.
I
Yeah.
just want to ask, Chizzy has a question. You know, her connection was bad. So she wanted to know the cost implication of the calcoscopy in Nigeria.
Okay. All right. So with respect to costing, that will vary from region to region. Okay. And that will also vary from whether it is covered by the insurance scheme or whether the woman is paying out of pocket. So the pricing is not yet standardized, in Nigeria, because people put pricing based on how they get their commodities, how they get the hospital consumables, how they are able to, the power up system. Are they using generators? Are they using lighting system? Do they need to call a visiting consultant to come and do the colposcopy? So there are so many. It will be quite unfair if I put a price tag on that. So it is individualized, but I must tell you, it's not something that will break the pocket. It's something that is affordable.
Okay, thank you so much. Ladies, would you agree that we can take maybe 2 more questions so that we'll let the good doctor go, because it's pretty late in Nigeria already? And we absolutely appreciate your time, your talent, and your effort at this presentation. And you have no idea how richly enriched that we each have been just listening to you. So one question that was forwarded, I know you mentioned during your presentation that you suggested 65 would be a good age to stop the screening, all things being equal. So do you recommend total hysterectomy for cervical cancer prevention in the case of a woman who has completed her family size?
That is another very, very, very intelligent question. All right. Okay. Now, in medicine, we use the mantra primum non nocere. First, do no harm. All right. So doing a hysterectomy for cervical, for precancerous lesion. I'm using my words very carefully. Okay, because there are 2 entities here, precancerous lesion and invasive cancers. So one is not yet cancer, but there are transformation. One is already cancer. That's the different treatment modality. Now, here is a woman that there is, in fact, all her screenings are normal, no problem, and she wants to remove her womb so that she wouldn't have get cancer. No, we don't recommend that because remember what we said, that if the individual has been screening and those screenings are negatives, they are normal, by age 65. I mean, now is it when she will now start developing? You leave the woman alone, all right? Yes. However, if maybe she has had subsequent abnormal pap testing, the recommendation will be not to necessarily stop. You may have to continue. Now, the issue of hysterectomy, even in CIN3, because remember that hysterectomy is a major surgery. Hysterectomy is a major surgery. So the surgeon has to dipole in between these 2 ideas. First of all, can this individual benefit from a conservative treatment, which can either be ablative or excisional? So there are some things that we can do, because the area, they are what we call transformational zone. I personally skipped all these details. I mean, everything you tell the report is so that it will not be too academic. Yeah. So in the cervix, there's an area we call the transformational zone. You can only see it with the with the microscope. Those areas can be cut off, because that is the point where you have very high activity of changing of cells, what we call cell replication. We can use what we call lip surgery and cut it off for CIN2 and 3, even though there is a controversy for CIN2. All right, so you can cut it off and you follow the woman up. by doing subsequent pap smear. That's enough.
Okay.
All right. However, if there is now a diagnosis of cervical cancer that is just confined, mark my words, I'm using it very carefully, that is just confined within the cervix. It has not left the margins of the cervix and touched what we call the parametrium, or has gotten to the side wall of the vagina, of the pelvis. I'm talking about staging now,
Right.
So if that, you can actually do what we call a radical hysterectomy. Radical hysterectomy means you're not just removing the uterus, you're removing the uterus, removing all of the thing that supports the uterus. Okay, so that is the treatment modality for a woman that's already can say stage 1 cervical cancer that is just confined on the cervix.
Okay.
But once you have moved away and got into the parametrium, it is called stage 2B. At that point, you might need to do more. If I got into a side wall, it's even worse off, more serious debilitating surgeries. But for the pre-cancerous cancerous lesions, we may not necessarily advocate as the first line of treatment for the woman to do a hysterectomy. Rather, we talk about the conservative management, which is either to burn, ablation, or to cut off that zone, which is what we call the lip surgery or the lids surgery, depending on the balance, whether United States or UK. Okay, so that's it.
Thank you so very much.
All right.
Before we conclude, Chizzy, do you have another question?
At the best price. You must have done a ton of research. Oh, we didn't need to. They use a cutting-edge technology.
Okay. So to complete our session this evening and to appreciate the time and just the gift you've given to us this evening, Dr. Igbodike, we're going to call on Dr. Cordelia Udoh to give the vote of thanks before we conclude. Thank you. Dr. Udoh.
Save up to 34% on certain GE appliances.
Dr. Cordelia, are you there?
Yeah, so now I can, you can hear me. I was talking with muted. I thank all of our speakers, listeners, and Dr. Igbodike, who has given us medical information to guide and potentially save our lives. Knowledge is power.
Yes.
And potentially a lifesaver. Igbodike is based in Lagos. Please refer your friends and colleagues and families to this expert OBGYN in Lagos. Thank you.
Thank you.
Thank you so very much. Our chairwoman, Lady Clem, do you have any final remarks before we conclude the evening?
Well, my only say here is a big thanks to this OBGYN, Dr. Emeka. It's really food for thought. You really gave us so much. And now, I'm beginning to think, because I know I practiced nursing and midwifery in Nigeria. And it was only one time that I heard about vaccinating the young girls. Vaccinating the young girls. Okay. So I don't think we have enough education on this. Because you see the cycle, if you get the vaccination from what you said here, between the ages of 9 and 12, that one, you don't need all of this, okay? It will be within your cycle. So I think we have to, as medical professionals in Nigeria, to promote this health education on vaccination. I know if mothers do know understand very well about this vaccination, they will do this vaccination to their young girls. Yeah, before it gets late. Thank you.
And boys, not
and
just
boys too.
Absolutely.
Yes, yes,
Yeah.
Thank you
That's
so much, Lady Clem, for that
Mm.
comment. Again,
Yeah.
Dr. Igbodike, I mean, this is our first serving of our Women's Health series. And I'll have to say that we started with a big bang with your presentation. So thank you so much for your knowledge. Thank you so much for your time and for coming out to be with us this evening. I know that most of our members, it was a very busy evening for a lot of them. So many of them couldn't make it to join in, but I know they would have missed when they realized just how much they missed. But I also texted you that on behalf of all of us here and those that were not able to make it, if you could kindly share your slides with us.
Yes.
Because even those that are present here want to get the slides to go through them some more. And I know that for the benefit of those that were not here, they would absolutely love to get the education that you shared this evening. So thank you so much. And we really greatly appreciate you.
And I also wish to thank all my friends that called in. Chizzy is a pharmacist. Chizzy Agoboa, Nia Agoboa, she called in from Nigeria. I also, Goredi, she's a colleague, registered nurse. I'm seeing her beautiful face. I hope you guys enjoyed the wonderful presentation. And the rest of you, thank you for joining us, and thank you so much. Please, Dr. Igbodike, plan to come again.
yes. We need him back.
And then members, I'm sure our moderators did good. So I want to say thank you to Dr. Udo for joining me to moderate this evening.
You're always the best. You know that. We will listen to you. We'll be here. Nothing up and still listening.
Thank you so much. Thank you.
Thank
And
you,
have a
Dr.
good
Juliet.
have a good evening, everyone. Thank you, guys.
Thank you.
Yeah.
Bye-bye.
Thank you for having
Thank
me.
you.
All right then.
Bye-bye.
Okay. Bye.